Do our hair. I'm gonna test 1 2 on my microphone. Are you gonna test 1 2 on your microphone?
Test 1 2. Where's my microphone?
Oh, girl, I got it. That's Diane Lynn, Enterprise Assistant Vice President, Advocate Health, Global Healthcare. We want to find out what's happening around the world with healthcare. Diane, say
Ah! I want to check in the back of your throat.
How do you feel about healthcare in the United States versus, well, first of all, when folks come to town for meetings for her, they travel internationally.
Yes. Mm-hmm. So in my role, I lead a lot of things. So all related to global health. And so it's patient services, and so it's for travel patients, domestic and international, that come to Charlotte, or they come to Winston-Salem, soon to be in Georgia. And then also we're working in the Illinois area for care. And when people travel for care, they leave their community, their support, everything, their primary care physicians, everyone is behind back home. So you come to some place where you know nobody, a time when you or your loved one is very, very sick, because normally you only travel if you're very complex. You need support. And so that's what my team does: care coordination and concierge services for travel patients.
Let's pick a country.
Sure. So you can say you're coming from Turkey.
Coming from Turkey to the U.S. for medical care specifically.
Correct.
They're talking to the doctors here, so the team gets together. I think that's fascinating how they
Yes.
come together as a team.
But normally a patient is self-referred. So if a patient is self-referring for care, so they've heard about us, or they've heard about a certain doctor and they want to be able to come, they'll reach out to my team, and then we'll handle the intake part. So we'll work with the patient to get their records and get them accepted for care here by a physician, and then we'll help them with their travel logistics and all that while they're
You got to
trying
be
to come.
accepted? Oh my God.
Well, you might not be appropriate to travel for care. So it could be, you want to come to the United States, but maybe your care that you're getting is appropriate. Or maybe there's nothing different that would have happened if you came here. Then really you don't want somebody to have to incur the cost of traveling and all of that. You do want to do what's best for the patient. So that's very important. And then there has been times where, the doctor says, well, hold on a second, let's monitor you, or let's talk with your physician. So we'll do a peer-to-peer, physician consultation, and it's all to do whatever's best for the patient.
I love it. Are you guys going to pay for the airfare?
Oh, no. They have to pay for themselves. But we do have wonderful partners, corporate partners, lodging partners, folks who own the hotels, and black, car services, things like that, that have partnered with us to make sure that we can give, really good rates and things for travel patients that come in.
Like those good rates.
Yeah, we love
those good rates.
And then there's other partners like Ronald McDonald House, Hospitality House here.
Angie over there.
Yes, Angie Bush. She's wonderful at Hospitality House, and she's doing a phenomenal job. And she's a very, very important partner for us, because when a patient comes in, they have to have somewhere to stay, and their caregiver has to have somewhere to stay. So if the patient is in the hospital, their person who comes with them has to have somewhere to stay. And you can think about how expensive that could get. If you're just in a hotel room and you're here for 2 weeks, that's a pretty big bill. So these are things that we do in order to make it easier and seamless for a patient to seek treatment here.
That's why she's the advocate,
That's
y'all.
why.
That's why she's the advocate.
That's what we want. And then I also lead international business development. So that's very important, because, there has to be brand awareness. You have to have relationships that you've developed out with other physicians, with universities, ministries of health, payers, the insurance companies. They all have to know who you are in order for you to get referrals from other places other than just self-referred patients. And so that's a lot of the work that I do, where I'm traveling and hopefully trying to get partnerships. Also, there's contracts, so different specialty services may do consultative services. And so it could be for clinical pathway development, things like that. And so those are other opportunities that I also pursue for the health system.
Do you ever hire comedians just to make everybody feel good about themselves?
I should. Yes, that's necessary. A good sense of humor is necessary. If you don't have that, you won't make it.
You will not make it.
You won't make
We're talking serious stuff.
Yes.
You need to find a gift.
Okay, I'm going to find a gift.
Because I'm going to ask you the difference between our healthcare system and other healthcare systems in the world.
Oh, yes.
We're worldwide, y'all.
Aha.
Diane Lynn is joining us this morning. She is our Enterprise Assistant Vice President, Advocate Health, Global Healthcare. Say that 3 times. What you picking?
Lego my Egos. I like these socks.
Those would be so cute with a skirt.
Oh, yes, I'm gonna pick these socks because I love interesting and peculiar socks. I don't know. I get holiday socks for my kids and my nieces, and I know I get on their nerves. I'm like, it's a Christmas sock day, and they're like, oh, she has the Christmas socks, because I will go to the Dollar Tree and get them because they come out with them, and why pay more than $1.25, right? And you're gonna lose one. So that's an investment. I mean, that's a bad investment. So we $1.25. I can get down with that till we can have these holidays.
We can get down.
That's it.
I just want to know, where do those socks go?
I have no idea. One of my earrings goes. They're together.
They live together.
They live together.
Not only is she smart, she's funny. She's cute as a button.
Oh, thank you.
And thank you for doing this, because you're doing this right before you go in the office.
Oh, no, I love it. This is it. I was excited about it.
Okay.
So I was very excited about
You want another gift so I can ask you anything else?
Yes, let's see here. You know what? Ooh, I know I need to get my nails together. Look, this is a bag of remembrance. What's this, my memory bag?
These are things that I walk around my house 3 times for. Where's the emery board?
Pumpkin seeds. Oh my gosh. Oh, crayons.
Do you color?
You know what? I just got one of those stress reliever coloring books at the Dollar Tree.
At the Dollar Tree.
And some colored pencils, because I guess you're supposed to do that, and it's supposed to be relaxing and this, that, and the other, and it just stressed me out because I'm like, I don't know if I should make this. Should I make this pink or blue?
Are you the type of person, when you cursive write something, it has to be absolutely neat, or you tear the paper up and start all over?
No, I do half cursive, half print, and my niece says this is calligraphy. And so I said, I made a grocery list. She said, please don't give it to me, I can't read it. So because
text it to me, Auntie. Text it.
It's calligraphy. It's old English.
So you got some Egos.
I'm gonna get the pennies.
Smart woman.
Because the pennies will be going away, and this right here is a collector's item. So hold on to your pennies, y'all. Do not throw them away. If you see one on the ground, pick it up. You're supposed to pick it up anyways, but we've been like, since COVID, don't touch it. Could be somebody's shoes.
Remember when we were wiping down groceries?
Yeah. The mail, everything that came. Yes.
I was looking at people side eye like, you need to be walking on the other side of the street.
Oh my gosh!
Like
right?
They had me almost cussing a lady out in the store, Trader Joe's, because she didn't have a mask on. I was feeding into that. I'm like, yes, get her,
put the mask on. We want this all to be over. I think that was really the hope, is like, one, nobody wanted to get sick because nobody knew if you could make it. And then 2, everybody was like, we're ready to be done. Can we all just do the same thing so that we can get this over with and done? But it's a virus, and so it will never be done, as we know.
What's a myth? Let's bust a myth in the healthcare system, because I want to compare U.S. healthcare to other countries. Mm-hmm. Like, are they like really wanting to come here, or are we really wanting to go there?
Well, I would say that the quality of healthcare worldwide has really been improving, which is a good thing. Okay. Which is a good thing, because we don't want it to be so lopsided that because what we found out with COVID is, because if there's not access to care in different countries and different areas of the world, if something were to happen, it is a very short period of time before it spreads across the entire world. Beside the fact, we are inextricably linked globally, and what does affect one part of the side of the world will and should affect the other side of the world. I would say should, from a standpoint of, if heart disease, if diabetes, if a lot of the non-communicable diseases are ravaging other areas and other parts of the world, and we have the knowledge to be able to do something about it, it's our responsibility to do something about it. The days of saying, well, that's over there and we're over here. Problem. Yeah, that's over. That's over. Fortunately, over the past, I would say 100 years, but really over the last 30 to 40 years, more health systems in the United States have been partnering and collaborating globally to be able to help lift up the healthcare systems in country around the world. And that's very, very important. Some have done bricks and mortar there. Some of them have their, name on it. They may have clinics there, or special type of specialty services that they provide within hospitals there. But that is very, very important, because it should be an all boats rise type of a situation.
Is our healthcare better in the U.S.? Say yes.
Okay, it is better in the U.S. It is better in the U.S. And I would say
Expensive, Diane.
I was going to say that. I was just trying to think of a way to say it. Uh, the outcomes are better. In some areas, the outcomes might be similar, but the outcomes are better. We've been doing things a little bit longer, much more spend in the area of healthcare here. So we've invested a lot. When you think about how much it costs for research and development, that's being done here in the United States. And we have so many university-based healthcare systems that are really, really tied into making sure that they're, pushing into the next generation of healthcare. What should we do about tackling different diseases and things like that. So because of that, because we're willing to invest heavily in it from different sectors, we're able to constantly be learning, and we're in that constant state of learning. But that doesn't mean that we're isolationists at all. Because when you think about a clinical trial, often if there's a site in the United States and they're running and trying to find efficacy for a drug or something here, they're also running sites in the world, because it's very important to see how a drug reacts in different, say if it's a cancer drug, and you have patients here that may be used to taking certain types of therapies or something. Maybe those therapies aren't done in other places, but you're going to try to see exactly how that drug may interact with patients that have had whatever type of drugs in their system versus those that are, or maybe had certain types of therapies versus those that didn't have those types of therapy, So it really is just seeing a variation, of the circumstances are different. So you'll see that a lot of times clinical trials are run, globally, but they might have been started and paid for here.
Is the pharmaceuticals generic across the board? Like, is in Europe, is their formulations better than ours here? Like, because pharmacies have to get involved too. Pharmacists, the pharmaceutical companies,
Right,
have to be involved. I'm assuming.
well, a lot of times of course they're part of it because they're running the drugs. I mean, it's their drugs, but no, the drug will be the same. It will be the same drug.
Okay.
If it is a drug, I can't say a drug name maker, but if it's a certain drug maker, it will be the same drug formulation here and there,
Just like,
because you got to prove efficacy on that drug formulation. Now, that's when you're going through clinical research and development. So when you think about how much money goes into that, because that's really helping to push, okay, this is the next level of therapies. This is the next, think about all these new semaglutide drugs and all that, the GLP-1s and all that. We know the names of them and everything, but there was a lot of clinical trials that had to go forward to make that happen. Now, once their patent is, no longer tied to them, then you'll be able to see generics that come into the market. But until that happens, they're able to recoup their money for all the money they spent for clinical research and development marketing.
would you suggest someone get into the medical field?
Yes.
Specifically African Americans. I know.
Yes.
Black African American, whatever
Yes.
suits your boat, baby.
I do, because I think we have to have more representation, but more representation in a diversity of areas. So I think one of the myths about healthcare is that it is only clinical. There's so much more in healthcare that is non-clinical. Now, clinical is important. Yes, that is the main crux right there. But if you don't have administrators that are helping to make sure that the bills are paid and the doors are open and the roof is not leaking and all of those kind of things, then it's not really going to work. Finance is important in that, so those that are interested in numbers and accounting and things like that look into healthcare for that. But then also when you think about business development, when you think about marketing, when you think about all of the different sectors around healthcare, strategy, that's another thing. None of these roles are actually providing health care, but they are providing support to the healthcare providers in order to be able to do what they need to do. So, don't just discount it because you say, I don't want to be a doctor, I don't want to be a nurse. That's fine. There's a lot of other areas in order that you can actually make a difference in.
And we can still meet the doctor of
And we
our
can
dreams.
see the doctor.
Mother said, marry a doctor.
You'll never see him. So, well, I mean, they're busy, Be the doctor. How about that? They be the doctor.
Be the doctor.
I think that there's so many myths about, still, unfortunately, about pain and things like that with regards to race that still exist. And we see that in some of the disparity in healthcare, and we saw, but I think one of the good things that's happening is it's been uncovered. Those thoughts, those beliefs, those preconceived notions have actually been uncovered, and they've been challenged. And we've been challenging people to really think differently and consider their biases. I am really, really proud of the work that Advocate Health has been doing around, making sure that they're addressing disparity in healthcare and making sure that there truly is healthcare for all, and realizing that the needs, not from a clinical standpoint of saying that you have to have a different type of care, but the needs of each community may be different based upon access.
Say the A word.
Access. So access to care is so important. And when you start to really think about all of these things that lead into why maybe there's barriers for access and how can we address them, then you as a health system are starting to say, okay, now we're going to affect health. Now we're going to affect the health of this community, because we have to consider all of the things that are leading into how you're not being able to access care. If you don't have access to transportation to get there, that's a barrier to accessing care. You could have the best care 3 miles down the road, but if you can't get 3 miles down the road, then that's a barrier to access for care. And so when organizations like ours are saying, okay, we need to lean into that, so that we're helping to address that, so that people can get to us, then we're really doing our job. And I've been very proud of the work that we've been doing around that, and we continue to do.
Data and technology, data and tech, because that's where we're going to, that's where we are.
Yeah. Mm-hmm. I think people get scared about data and healthcare, and they're like, and technology, when they're looking at, okay, well, AI and all that kind of stuff. How are we going to use that? Is that going to replace people and all that stuff? No, the purpose of it is really just to make it more accessible, thinking through, process and things like that, in order to improve things, to make things happen probably faster and be a little bit more efficient. So if we can create efficiencies, then that always, hopefully in the long end, will end up lowering costs and things like that for healthcare and increasing access for all. So data is very important. As a matter of fact, before I go into any room, the data goes first. I mean, data opens doors that bias, that are closed by bias. I mean, because a lot of times, particularly as a minority woman coming in a space of leadership, I mean, I've been in meetings before where I've said things, shared a fact or an understanding that I have, and people will ask someone who came with me, maybe one of my direct reports that came with me, if it's true that is not a person of color, and so I have to say, so you take that in, because you remember, you focus on and the reason why you came in that room, and you do not let that knock you off your square. But we do take that in and we don't forget it. But it also, helps us to remember the fact that we still got a ways to go. But we're not there yet. But data comes through the door with me, because you might cross your arms because you don't like that I'm in that seat, and you might cross your arms because you don't like that I'm presenting this to you. But what you can't argue with is the data. And so a lot of times that gets us down the road further than, when I realized that, I was like, oh yeah, that comes in before me every day. But as far as data with healthcare, it makes the outcomes better. The more information we have, the more we can understand what's working, what's not working, where we need to invest, more to be able to find out better solutions, maybe process improvement, best practices. All of that is understood through data. So the electronic medical record or the electronic health record, which we all love having because nobody wants to have to go back to the days where you had to get paper records from your doctor. Hey, what do I have?
We got a file. We're walking in with a file.
That's it, with a file.
Where my doctor at?
That's exactly right. Yes. So because of that, it helps for continuity of care. If a patient, it has been for a long time, if a patient stays within their own health system, then their records, if they have an EMR, then their records will stay within that health system. So when you go in and you give them your name, they look you up, and then they can see all the things that have happened to you, all your medications and stuff like that. That's super helpful with regards to continuity of care, feeling like people, the doctors understand where you're at, what you're doing, and all that kind of stuff. So that's very important. Electronic health record is not new. I mean, it's been here for like back in the 60s. It was adopted in the 70s by the Department of Veterans Affairs. So, but it was very, very expensive. So that's why it really wasn't widely utilized. And it wasn't until the 2000s through the American Recovery Act, meaningful use, and the government started to invest in the EHR, the electronic health record. And that's when hospitals started to be able to afford to start transitioning over into that out of paper records. We are so far ahead in the United States with regards to that. Other countries are starting to catch up. There's a lot of homegrown systems in other countries that, of course, they don't speak to each other. They don't integrate with anything. A lot of countries still do the paper records. And because of that, these are areas of, growth and opportunity in the future for other countries for global health. It does make it difficult for patients because there's some countries where, depending on if the government owns the hospital, they're not able to get their records, because if the government owns it, then the government owns your stuff. So it depends as well. So when you're seeking care maybe somewhere else, if you have complex care or you have a different type of a need, it can make it a little bit difficult for patients. And so we work with all of that. But data and technology has really, really helped us to move forward in healthcare. I mean, when you think about AI, right now, it's some of the uses that we're having. Of course, we have predictive analytics, which has been going on for some time with regards to surgery, which has really helped in surgery outcomes, where they're able to feed in all the information about the surgery and the patient and all that kind of stuff, and start to and understand different ways to maybe attack something in surgery, have different approaches that can really help with the outcomes of the surgery. So that's been in use for quite some time. But doctors are being able to use it for transcription services as well. So where it used to be, you go to the doctor and they'd be sitting in front of the computer and you're talking to them and they're sitting there clicking because
wait a minute. Let me do a little.
That's it. Yeah. And you're going, did you hear me? I don't know. And then you feel like a hypochondriac because then you say, because then my leg, and they're not looking at you. They go, okay, yeah, what's wrong with your leg? But my shoulder, you're not really. They're not engaging with you because they have to capture all of this stuff during your appointment. And that's very important. But using AI for transcription services during that appointment, where the AI is picking up the conversation and transcribing it for the doctor, allows the doctor to be able to engage with you, not sit there at the computer, and you really do have a much, much better encounter during that time, and you feel heard, and the doctor feels like they can really give you better care, and everything is being picked up by the system.
Right.
Wonderful use of time. And then also that's an efficiency. So afterwards, if they're not sitting there at the computer, then and they're taking it in, then they have to stay after and chart and put in your chart, and do all that stuff. That's more time there. So these are creating efficiencies, which is better for the patient, better for the doctor, and more efficient, especially for the care.
We should not get jealous because other countries say their health care is free. Because I used to get real mad.
Yes.
But what kind of care?
There are different models, of course, and it would be lovely. It would be so lovely. All of us think it would be lovely if we could have free health care. And that's something to aspire to in the future. I mean, we would love to be able to have that. We are not there yet. But I can say that the quality of care that we have especially working with international patients and national patients. There's domestic patients that travel here for care. So that's important to know as well, because even though we think about, okay, well, international patients, they must be coming from countries that are maybe deprived. No, no, no. These are coming from also high income countries. It's not low income countries or middle income countries. It's also high income countries where they have good health care, but maybe they don't have certain therapies or services, or maybe we might have better surgeons, or maybe we have been doing something a little bit longer. And so, yeah. So it's not just that. It also is not just rich people either. So because of insurance companies really expanding their insurance products to be able to have more affordable options for patients globally that can now travel for care, it has opened up the whole world. And that's why we see a lot more different types of cases. And I think it's so important for healthcare systems to do this, the opportunity to be able to treat different types of cases, of seeing different things that you've never seen before. That's very, very important to doctors. That's important for education. That's important to even better the healthcare that you're able to provide to your own community. The more exposure you've had on different types of cases, the better of a physician that you are. And I think the physicians love it. They really do. They like it. I also lead the International Physician Observership Program, where we have doctors from all over the world that come and shadow our physicians and they learn from us. But that's an exchange, because our doctors also learn from those doctors, because a lot of times we lean into the technology we have, but absent having that technology, and you have to do these things, sometimes by hand, you learn how to do things by hand, and that even grows their skill sets. And so those types of exchanges are very, very important, especially when you think about attrition with healthcare, physicians and other healthcare professionals, being able to offer them opportunities that they normally wouldn't get, being able to see different types of patients, and that's fill your cup stuff.
Yeah.
It reminds them why they got into medicine.
Culturally divine practices.
Yes, that it's exciting work. It is. It's very exciting work. Mm-hmm.
Speaking of culturally divine, being a woman,
Yes.
African American, do you like African American or black? Because we get to choose.
Black.
Black. Black.
African American is fine.
Mhm.
But most of my life I was black until they said African American. So we do that, but I'm a black woman and that's fine.
And when you walk in the room,
yeah.
First of all, are you 5'9"?
Well, yeah. So I just had this conversation with my son last night. I used to be 5'10", and he came in the house last night all extra tall. And I said, "Oh, you've grown." He said, "No." And I said, "Oh, I must have shrunk again." He said, "You keep saying you're shrinking." Yeah. I said, "Well, if you're not growing, I'm shrinking." But yeah, I think I'm about 5'9".
And with heels, we're talking about a 6-foot, beautiful black woman.
Oh, thank you. But I love it.
Yeah. So when you walk in the room, I know you've got this fun side, but the analytical side. Now, I love this combination because you're able to spot whatever's happening before it happens.
Ooh, girl, that's self-preservation.
People don't understand. We can see you.
We have to. Oh, my gosh.
We can see you.
I think one thing that we do very well as Black women is we observe, because we're always looking for safe places. And we have to very quickly assess the situation to find out if it's safe for us or if it's not safe for us. And that's in business, that's in a community, that's at the grocery store, that's where you park your car.
When we date.
Who you date, that's everything. Schools for your children, healthcare, all of it. We are constantly taking the temperature for safety. And so we're really great at observing things. And I think that makes us wonderful leaders, because we're able to, assess the situation. We have to come up with about 3-4 different scenarios of how this could go down, and understand how we can set a really quick process to understand how we can navigate and maneuver through it. Because it doesn't mean that we back out of a situation. It means we have to proceed with caution and find out which is where's the quicksand. Because we do that, people say, you think so fast on your feet. Oh, you're so innovative. Don't you come up with great solutions, and you're so calm. I learned a long time, be the lid on the fire. If you're able to be the lid on the fire, you can calm the situation down enough in order to figure out what's the next step. but we live like that.
What's our nervous system look like?
Oh,
I don't.
it's shot. It's shot.
No, wait a minute. I don't know why I was saying this. It's our nervous system, y'all.
There, let me crack open these things. We have to talk. No, let me just preface this by saying that this is in the United States. When I'm in other countries, I am treated entirely different. I mean, they appreciate my experience, the expertise, and the reason why I'm in the room. They want to hear what I have to say. In the United States, it's a little bit different. It's a lot of bit different. But I have to constantly prove why I'm sitting in this seat. Regular occurrence where I might be having a conversation with someone and I'm talking about, somehow we segue into something I'm working on, a project or something. And they'll go, that's fascinating. Who do you report into? Because we really do need somebody to lead this. All the time. And I have to say, oh, well, that would be me. This is what I do. And this is who I report into, but this is what I do. And this is what. So did you have another question? But I immediately know this is not a safe space for me to have discussions in really further. And so if we have to continue to communicate or we have to work together, we can work together. But I now know you don't see me in my space, in my place, as legitimately in my place. And you're looking around to say, where's her handler? Who's got her? Does anybody got, because we need somebody. And if I know that, then I know how to govern myself accordingly. Like we say
we are the chef, we are the agent. Sometimes we are the physician.
So that happens on a regular basis. Now, when I, and it's unfortunate, I still have to get things done in spite of that. People say, oh my gosh, and I've had this even in reviews, they say, you're resilient. I never know how to respond to that, because half of me wants to say, because I gotta be. But the other half wants to say, because I would like to not have to be.
Because I would like not have to be.
When I think about resilient, I think about, remember when we were kids and you had those things, the blow up things, and
it'd
be like a clown and you punch it or you get, and then bring and then come back up, almost like a weeble. Remember the weebles wobble, but they don't fall down. That's resilient. To me, that's what I see about resilient. You can take it and you get right back up. You can, and then when they say that, I see them things going ding like that. Black women talking about, the whole strength thing and people saying, you're so strong, girl, you're strong. It's like, I have to be.
Mm-hmm.
We have to be. We learn strength. We were born from strength. That's it. We have to be strong, because when you're in a place that strength means survival. If you're not strong, what's going to happen to you? So enjoy that. I want you to take a wonderful bath and get all.
Oh, is this a roll?
It's a roll.
Oh, because we love our fluffy little blanket. Oh my. Spa day, here I come. It's got Atrium Health on there.
Yes. And so I wanted to say thank you so much.
Let me do official.
That's it.
Official. I'm officially a Atrium Health Spa Day girly.
Spa Day girl. Yes.
Ooh, I'm so rich. Pick out a gift. Pick out a gift, girl. Pick out a gift. Because you got your pennies in your egg.
Yeah, I have my penny. Yes. I think the next one I'm going to do is, let's see here.
So good.
Let's see. Okay. I'm going to take these because I use these when I travel. These right here are my travel buddies.
And when you need one, you don't have one.
And you don't. No, I don't. So I need, and I need one of the spray ones too. So I'm going to get this here. Oh. So I got my socks. I got my travel things, and I got my pennies. And something about this says something about me.
These are going international.
That's going international.
Because I will drink my products before TSA gets them.
Oh, right. Yeah, you can find me on LinkedIn as Diane Lynn. I want to say that thank you so much for this opportunity. I really do appreciate it.
When we first met, I'm like, she getting in the car.
That's it. Getting in my crazy stories. We didn't even get down the road on those ones because my life is...
Diane at a party had me on the floor.
Oh my gosh.
Everybody was literally, they couldn't take it. They had to leave the room. She's still telling stories. It
I
was so funny.
Oh,
Okay, go ahead. Go ahead.
I
I'm
was
sorry.
talking to my kids last night, and I said, "Well, I don't know what stories. My stories always tend up to a little bit strange and make people think, some type of therapy is needed. But we gonna get through it." But thank you so much for this opportunity. I truly do love what I do. My hope is that Nelson Mandela said that it's in our hands to make the world a better place for all who live in it, and I believe that. I believe that it's in our hands. We have a finite amount of time that we're on this earth. In the grand scheme of things, what did you do with it? What did we do to impact our families, our communities? What is your legacy? What is it? And if you can make it a little bit better for me with what it is that I do, every patient that we help, we've impacted generations. Because if we've given hope, because if somebody travels for care, they've already been seen wherever they could be seen closely. That if they've had to come to the United States for care, if they've had to come here from Alaska or from Hawaii or from California, they have already sought care somewhere else. When they come with all the hope. We impact generations. When we help a child and they're able to live a full life, when they haven't even started yet,
Yeah.
and we give them a chance, oh my gosh, that child will have children, and that, I mean, with generations. Legacy. And that's the work that we you look good. That looks good on you. Okay, plush. I love it. That's a good soft one too. Mm-hmm.
Oh my God. Oh my God. Now I'm going to get some beauty products from the dollar store.
That's the best place to go.
Diane, I can talk to you. We have to do maybe a part 2.
Yes.
And this will be her stories.
I have to tell you about the guy in the desert who was a fire eater in Dubai, and the dancer in the Shangri-La thing, that ended up stalking me. Oh God, that was interesting. It was very interesting. But
Did he give you any of that chocolate? We might consider if you give us some of that Dubai chocolate.
No. He kept telling me he loved me. He didn't even know me. But yeah, it was interesting.
You almost got married.
I almost got married to a fire eater in the desert.
Can you imagine what the wedding would look like?
Oh, it'd be camels. It was interesting.
Diane, you gotta close this out because I can't do it. Thank you for joining us for an episode of Curbside Curiosity. That is Diane Lynn.
So I'm the Enterprise Assistant Vice President of Advocate Health Global Healthcare. Period.
Thank you.
Thank you. Bye.